Hello everyone, my name is Jasmine and today I am going to do my perio presentation. I'm going to introduce my patient. He is a 35-year-old male. Some history on my patient is that he does not have any systemic diseases. There has not been any changes in his general health within the past year. He does not remember the last dental visit he had. He does have bleeding gums when he brushes and flosses, and his teeth are sensitive to cold. This patient does use a manual toothbrush. The reason why I decided to do my presentation over this patient was because of his periodontal probings. So when I started charting his periodontal probings, the numbers did not look great, but they also did not look bad. So he did have some 5s and 6s, and in the area where he had the 6s was more posteriorly. I explained to him about the wisdom teeth and how sometimes those wisdom teeth are hard to get with his toothbrush, and how that is pretty much enabling that bacteria to harbor around them. On the FMX we took the first time he was in the clinic, you can see the radiographic bone loss and just kind of where the big pieces of calculus were, and where that calculus was harboring that bacteria, which was helping to the bone loss in a way. So his periodontal risk came back high. He did have, like I mentioned, and like you guys saw on the x-rays, 31 teeth, 37% of bleeding on probing, and he did have 33% bone loss. So that was what put him as a high risk for periodontal disease. And these bite wings, like you can see, he had this fractured tooth, and he also had deeper pockets on the areas on those posterior teeth. These bite wings were taken kind of post-op from his treatment, but he hadn't quite finished his entire treatment when the bite wings were taken. Same thing with the panel. The panel was taken after one site was treated, and then we took it a year later. On my periodontally involved patients' EI pretreatment, everything looked within normal limits. For the gingival description, however, the color was general erythematous. For the shape, it was general rolled. The papilla was general pyramidal. The consistency was soft and spongy. And for the texture, the free gingiva was smooth. The attached gingiva was stippled. The position of the gums were there was local recession, especially in sextants 3, 4, and 5. He did, like I mentioned, have number 4 missing, and 20 was cracked or broken. Fractured, I should say, sorry. The occlusion was a class 1 for the right side. The left side was a class 2 with a division 1. He did have 20% overbite, 3 millimeter over jet, and 4 millimeters to the right for his midline. So after reviewing the bleeding, which was generalized, the supra was very dense, and the sub was also very dense. The pocket were generalized 4. Like I had mentioned before, there was a couple 6s, 5s, and 6s. The extrinsic stain was moderate, so that put him as at a CNC class of a 4. And with all these factors playing, the reason why I decided to put him at a periodontally involved patient of a case type 2 grade B was because, like I had mentioned before, this was the first time I was seeing him, and he did, have that bone loss, those deeper pockets, and his home care was not the greatest. These are some of the post-op, pre-treatment intraoral pictures. Like you can see right on sextant 2, there was calculus and the bone loss. Sextant 5. So then we decided to do an oral DNA on this patient. His results came back very high. There was a big presence of PG bacteria, and when we started learning about periodontal disease, all of these things were playing in the back of my head, just because I knew that something was going on with this specific perio patient. He wasn't really going regularly to his medical doctor, so it kind of made me wonder, like, if the bacteria in his mouth would affect later on his overall health. And like we learned, these bacteria are big factors to, systemic diseases. So I went over this with him. I told him, these bacteria in your mouth can lead to, systemic diseases such as diabetes, cardiovascular diseases, and just all this other systemic diseases that people don't relate to within their mouth because they think that the mouth is not part of the body. This is his chart. He did have a couple of areas of concern just by looking at his x-rays and looking in his mouth. We did refer him over to a dentist to take a look at those areas of concern. For the treatment plan, for the first appointment, I did plan for a PSA IO laser, NSPT on the upper right, LAPT for tooth numbers 2 and 3 where those deeper pockets were at, and Arestin placing on those teeth as well as SCF and topical fluoride varnish. For that same appointment, I planned on doing an IA, a buccal, my laser, NSPT on that lower right, and LAPT on teeth numbers 30, 31, and 32 where those bigger pockets were as well, with Arestin and SCF and fluoride. For the second appointment, I planned on working on the left side, upper and lower, performing the NSPT, the LBR, the injections, as well as LAPT and Arestin on those deeper pockets and SCF. When he came back, these were his post-op treatment intraoral pictures. The patient was very receptive and was interested in getting treatment done to see the results. And then when I explained the oral DNA results to him, he was like shook because he said, what does bacteria in the mouth have to do with systemic diseases? And I was like, well, in fact, it has a lot to do with systemic diseases. It can lead to, developing them. What I learned is that time is a great factor to consider during treatment for periodontally involved patients. So background story that I should have mentioned at the beginning was he was used for all my finals. But he was a great patient because he had all those deposits of calculus that we were looking for. And so I honestly, since it's Rangeley and it's such a small town, I wanted to keep him for every final. So I put off his treatment, which I know in the real world I would not do that because that is their health. But like I mentioned, he was my board's patient, so that's where this comes into play, like what I would have done differently. Honestly, if he wouldn't have been my clinic board's patient, I would have finished him the second I would have had the opportunity, just because I really would have liked to see the end results. I got a really good satisfaction at the end when I saw that I finished his treatment, but it wasn't enough time for me to see if what we did was sufficient for him. I did talk to him about, going back to the clinic where he would like to go, and just having that 4 to 6 week evaluation and just making sure that what we did on our side was effective, and that the LAPT, the fluoride, the SDF, everything functioned for him. And he was very receptive. Like I had mentioned, he did say that he was going to follow through with all that, and that made me feel a little bit of an accomplishment. But like I said, that is what I would have done differently, because that would have also helped me get more of that post-op evaluation together, like the x-rays and those periodontal probings, updated ones, because those were the ones I initiated with. And unfortunately, I wasn't able to probe because I finished him and that was it. Like, I couldn't have that evaluation anymore because I was running out of time. So definitely I would have started him earlier, but I'm glad I was able to finish his treatment, and I really hope that, I will continue to see this patient. So I really hope to see that change once I'm out in the real world, and hopefully what we did really worked for him, because at that point I will feel like I did my part, and also him doing his part at home. We did over those periods of time where he was my final. The OHI that I gave him was proxy brush use because he absolutely hates floss. So I needed to find a way for him to get interdentally inside those gums. So I taught him about the proxy brush, and he bought a bag and put it in his car, in his nightstand, and in his work office. So that was great. That made me feel like I did something where I was accomplished with that whole OHI. And also, he started using mouthwash, which is a big changer because he started noticing, before even coming back to finish his treatment, he's like, I never realized that mouthwash is very beneficial for you, not only for the odor and stuff, but just overall. Like, I can go all day without brushing. Of course, he brushes in the morning and then at night, and I can notice that difference. So right then and there, I was like, okay, I've accomplished that, teaching him OHI. So that was it for him. This was my presentation, and honestly, it was an accomplishment to see those pictures that they honestly don't disgrace everything that we did, but we did it, and I'm happy we did what we did. Thank you, guys.